In this lecture, we'll be discussing meninges, CSF, and clinical applications. So just to cover the basic anatomy of the meninges first, we have the pia layer, which we can see here is just tightly adherent to the gyri here. We have to peel off the outer arachnoid layer here to see the peel layer. All right, so the pia layer then is just tightly adherent, and it's also vascular, which we'll see has an important clinical application. The arachnoid, in contrast, we can see it extending over all of the sulci and depressions here. So there is a space, if you were just to put your finger here and slip it underneath this arachnoid layer and resting on a gyrus, you would be in the subarachnoid space. And clinically, this is a very important space. There are areas of focal enlargement of the subarachnoid space. These are called cisterns. And there are two that are particularly important. One is the cisterna magna, which I'll show you in just a minute. And the lumbar cistern is a very large pocket of subarachnoid space that extends just below the base of the spinal cord. Right, so here's just a drawing so we can see we have the pia layer, the arachnoid, and then we will discuss the outer dural layer. So in the subarachnoid space, normally this just contains cerebrospinal fluid. Okay, so there are a couple of things that can go wrong here in this space. One is if we have an aneurysm that ruptures. And an aneurysm is, we'll discuss in more detail later, but this is a weakening of the blood vessel wall where part of the blood vessel just starts to protrude and kind of, slowly enlarge, somewhat like a balloon. And if it reaches a certain size, this can rupture. And the blood vessels then, since they're on the pia, when the aneurysm ruptures, the blood goes into the subarachnoid space. And so we call this a subarachnoid hemorrhage because the blood is in the subarachnoid space. Okay, the other thing that can go wrong that can involve the subarachnoid space is that we can have an infection. All right, and so this is known as a meningitis. And we'll say a little bit about this here at the end of the lecture. And so for both of these conditions here, we have abnormal cells, red blood cells in the case of a subarachnoid hemorrhage, white blood cells, inflammatory cells in the case of a meningitis. And so in both of those cases, it's helpful, always in the case of a meningitis, to get some fluid from the subarachnoid space. Right? So realizing here that this lumbar cistern lies below the base of the spinal cord, then you can safely do a lumbar puncture here, where we put the spinal needle in, down around L4 inner space, and you're not going to damage the spinal cord because remember your spinal cord ends at T12, L1, and then below that we just have this pocket of fluid, the lumbar cistern. All right, so we'll do this to make a diagnosis in terms of what type of meningitis the patient has, and it is sometimes indicated in a subarachnoid hemorrhage. Okay, so again, normal contents, cerebrospinal fluid. If we find a lot of red blood cells, the patient had a ruptured aneurysm or subarachnoid hemorrhage. If we find a lot of inflammatory cells, the patient has a meningitis. And then we can do studies on the spinal fluid to determine is this a bacterial or a fungal or viral meningitis. So the other focal enlargement of subarachnoid space is here, the cisterna magna. You can see it kind of lies underneath the cerebellum here and dorsal to the medulla. In the olden days, I knew a neurologist 25 years ago who still performed cisternal taps, where he would take spinal fluid out of this cisterna magna. And I'm not aware of anyone that's doing those nowadays because you can imagine there's a safety issue here with that. All right, so we have the pia, the arachnoid, and then the outer layer is the dura. And the dura itself actually consists of two layers. There's an outer parosteal layer, which is adherent to the skull or the cranium. This is vascular, and we also have nerves in this outer parosteal layer. And then we have an inner meningeal layer, which is itself attached to the arachnoid. Now, we'll see there are important separations between the outer and inner meningeal layer, and this is where the venous sinuses lie. So when we talked about the superior sagittal sinus, for example, that lies between these two layers of the dura. So there's an important potential space that lies underneath the dura, so above the arachnoid and underneath the dura, and this is called the subdural space. Very important clinically. We also have a space that lies between the dura and the bone, and this is called the epidural space. Again, very important clinically. All right, so this drawing nicely shows here, you can see the cortex and the pia tightly adherent to it. We can see some blood vessels there. And so this in blue is the arachnoid. And so the space right in between the pia and the arachnoid is the subarachnoid space. So again, an aneurysm here, blood would go into this space and cause a subarachnoid hemorrhage. And then here we have our two layers of the dura, the outer parosteal layer, which is adherent to the skull. And then we can see there's an inner meningeal layer. Okay, and this projects down to separate the right and left hemispheres. So this is the falx cerebri. Okay, but it's a reflection of the dura, pia, and arachnoid, but not the outer parosteal layer. And you can see in between the inner meningeal layer and the outer parosteal layer, this is where we have the venous sinuses. All right, now here we can see the outer parosteal layer right here, adherent to the skull, and also the inner meningeal layer. Both of these together are out in this location. And so in a case of head trauma, we can have blood that is underneath the dura, and this is called a subdural hemorrhage. This is very common, especially in the elderly that have fallen, they hit their head, and these don't always come on acutely. This blood can kind of slowly build up, but you can imagine over time this may cause headaches. If there's a lot of pressure in the brain, the patient may have some focal weakness or other symptoms of cerebral dysfunction here. All right, so a subdural hematoma here is always something we want to rule out in an older individual, typically that's fallen and hitting their head. This is venous blood, and so the trauma causes shearing of these bridging veins. Okay, and so we have this venous blood that kind of leaks into this subdural space. Now, an epidural hematoma, in contrast, is much more common in younger individuals. What happens with age is that the outer parosteal layer here gets more and more tightly adherent to the skull. So that's why epidural hematoma is not so common in the elderly. But a younger individual here with head trauma, and here we can see a skull fracture, which is highly associated with the development of epidural hematomas. And notice that this is arterial blood here. So usually in epidural hematoma, we have laceration of the middle meningeal artery. And in contrast to subdural, these often have a focal, just kind of a wedge into the brain. And so this is, both of these really neurologic emergencies because they're very treatable. Surgically, you can evacuate the hematoma of both an epidural and a subdural hematoma and relieve that pressure. So you need to be able to distinguish, and we're not up to our neuroradiology lecture yet, but I'm still going to put this in here, what an epidural and a subdural hematoma looks like on a brain scan. So this is a CT. How do you know it's a CT? Well, the skull looks bright on a CT scan, so that's always a giveaway. And so really there are only two things that are allowed to be bright on a CT scan. One is anything that's calcified here, like the skull. Here we have actually some calcified choroid plexus, so that's normal here in the lateral ventricle. But then we have something else. The other thing that can be bright on a CT is an acute bleed. All right, so here we have a focal wedge into the brain. So this is an epidural hematoma, which we can see over here. Okay, so if you get that focal wedging into the brain, that's an epidural hematoma. And remember, these are associated with skull fractures, which you can see right here. Now, subdural hematomas, in contrast, tend to layer out along the entire surface of the brain. So remember, this is venous blood. And one thing we'll notice here, and I'll say more about this in our neuroradiology lectures, some of this is bright and some of this is dark out here. And this helps us to kind of date the hemorrhage, because acute blood looks bright, and after it's been sitting there for a while, it starts to get dark. And so I won't go into the hours and days and all of that now, but just to know that the different signal characteristics can tell us about how long ago this happened. Notice that this is causing pressure on the hemisphere because this is the right lateral ventricle, and here we don't see at all the left lateral ventricle. How do we know what is right and what is left? Well, when you're looking at a head CT or an MRI, you always have to just imagine the patient is lying on their back, their feet are coming out toward you. So this is the right, and this is the left. All right, so the dura covers not just the brain, but also the spinal cord. And we've seen in lab the falx cerebri that separates the right and left hemisphere. And we also have the cerebellar tentorium, which separates the occipital lobe above and the cerebellum below. And also the temporal lobe kind of sits on that edge of the cerebellar tentorium. So below the cerebellar tentorium we have the cerebellum, but also an opening for the brainstem. Okay, so significant here is that if we have pressure in the brain and that pressure gets transmitted down, then the uncus, which is kind of sitting right on the lip of the cerebellar tentorium, can be pushed over the edge of the cerebellar tentorium, and that is called uncal herniation. So here we have a patient with a subdural hematoma. Here is the cerebellar tentorium right here. And so you can see that the uncus is getting pushed over. Now that's going to compress on the brainstem, and this usually has a devastating outcome when that happens. All right, so from lab, if we look at the undersurface of the dura here, we can see the falx cerebri, and then here is the cerebellar tentorium. Okay, just another picture of the falx, cerebellar tentorium. Okay, the falx cerebri, cerebellar tentorium. All right, now the cerebral ventricles and CSF. These are C-shaped structures in the brain. So here we're looking at the cerebral ventricles, which cerebral spinal fluid is initially produced in the ventricular system. And we'll see how it gets out to the subarachnoid space here in just a minute. And so the lateral ventricles, this is what we're looking at here, all the lateral ventricles, these project into different lobes of the brain. And so this portion projects into the frontal lobe, so it's called the frontal horn, or the anterior horn of the lateral ventricle. This is going back to the occipital lobe, so it's called the occipital horn, or the posterior horn of the lateral ventricle. And then this, you kind of need to imagine this is going down. Maybe this should be a little bit smaller to be more accurate, down into the temporal horn. So this is called the temporal, or the inferior horn of the lateral ventricle. Okay, and we have a central body of the lateral ventricle, and back here we have the trigone of the lateral ventricle, which kind of joins with the three parts here: the occipital horn, the temporal horn, and the body. So the trigone would be right about here. All right, so here are the lateral ventricles, and again, it's just important to know when we have a C-shaped structure in the brain, because when we're looking at CT and MRI in particular, if you have a section like this, well, you're going to see the lateral ventricle here, but you're also going to see the temporal horn down here. Okay, so here again are the lateral ventricles. Okay, so most of the CSF is produced here, and from here it goes down through an area called the foramen of Monro. There's a foramen of Monro that connects both the right and the left lateral ventricles with this central space here, and this is called the third ventricle. And it kind of has the appearance of the head of a bird, perhaps. This little circle right here is the interthalamic adhesion that connects the right and left thalamus. So remember, the third ventricle you want to associate with the thalamus. Thalamus is on either side. And the hypothalamus would be on either side of the third ventricle here. From the third ventricle, cerebral spinal fluid travels down through the cerebral aqueduct down to the fourth ventricle. And from the fourth ventricle, CSF gets out into the subarachnoid space. Okay, so here we can see CSF in the lateral ventricles. It goes through the foramen of Monro, which is kind of really where these arrowheads are. And this space right here, which is labeled foramen of Monro, this is actually the third ventricle right here. So it'll be a little bit confusing. So from the third ventricle, this flows down through the cerebral aqueduct into the fourth ventricle. And from the fourth ventricle, the CSF gets out through these outlet chambers. We have two lateral chambers here called the foramen of Luschka, and there's a middle outlet chamber called the foramen of Magendie. Okay, and so via these outlet chambers, the CSF gets out into the subarachnoid space. So here's the subarachnoid space coating the spinal cord. Here would be the lumbar cistern down here. And here's the subarachnoid space coating the brain. Okay, so CSF again gets from the ventricular system into the subarachnoid space. Now, not all of the CSF is produced in the lateral ventricles. So there's a little bit produced in the third ventricle and a little bit even produced in the fourth ventricle as well. But the majority is in the lateral ventricles. All right, so I would just encourage you to look at the diagram here. Start in the lateral ventricles. So we have choroid plexus producing CSF, going through the foramen of Monro to the third ventricle, and then through the cerebral aqueduct to the fourth ventricle, and then the little hole here is the foramen of Luschka, and this central area here is the foramen of Magendie, and then CSF gets out to coat the brain and the spinal cord. Okay, and this has a kind of a protective cushion effect. And then we'll see CSF finally has to drain through the venous system. So it gets out through these arachnoid granulations. And so this is the superior sagittal sinus here. Okay, and from our last lecture, you can follow the superior sagittal sinus to the confluence of sinuses and then out through the jugular vein, ultimately. All right, so how does CSF get here from the subarachnoid space out into these venous sinuses? Well, it turns out that the pressure in the subarachnoid space is just slightly higher than the pressure in the venous sinuses. And so there's almost kind of a pulsatile, continual flow of CSF from the subarachnoid and into the venous sinuses, the superior sagittal sinus. Maybe a better picture here. And these little outlet pockets here are called arachnoid granulations or arachnoid villi. All right, so important to know the content of the CSF. There are no red blood cells or white blood cells in the CSF. So remember, if we find a lot of red blood cells, we're concerned about a subarachnoid hemorrhage. If we have a lot of white blood cells, we're concerned that the patient has a meningitis. Also extremely important to know that glucose in the cerebral spinal fluid is 2/3 that of blood. So whenever we do a lumbar puncture, one of the most important things we need to check is what is the glucose. But we also need to compare that with the blood or the serum glucose as well. So normally it's 2/3 that of blood. You can see very little protein in the CSF, only 0.5% that of blood. So again, the CSF serves a very important protective cushion effect around the brain and the spinal cord. The brain literally floats in the CSF. Also very important for filtering out toxic substances. And in recent years, there's been a lot of discussion about the glymphatic system, not the lymphatic system, the glymphatic system, which are perivascular pathways where these toxins essentially are eliminated. Most importantly, probably amyloid beta. We will discuss this is bad. It accumulates in Alzheimer's disease. And so the lymphatic system here is important for getting rid of toxins like amyloid beta. So let's talk about some things that can go wrong with this whole system. First of all, we can have something called hydrocephalus. Now, normally choroid plexus makes about 500 cc's of CSF per day, which is quite a lot when you consider that all the CSF in the ventricular and subarachnoid space at any one time is only 150 cc's. So what does that tell you? That tells you that this normally circulates very efficiently. And it needs to circulate very efficiently because of all the CSF that's being produced every day. So if we have a blockage in the flow of CSF, we can get what is known as hydrocephalus. And hydrocephalus, there are two true types of hydrocephalus, a non-communicating and a communicating. And then there's kind of a pseudo, not real hydrocephalus called hydrocephalus ex vacuo. So a non-communicating hydrocephalus means that we do not have communication between the ventricular system, the lateral ventricles, the third ventricle, and the fourth ventricle. So for example, let's say we have stenosis of the cerebral aqueduct, which is right here. Okay, if this is very narrow and CSF can't communicate between the third ventricle and the fourth ventricle, what's going to happen? Well, the CSF is still being made, right, in the lateral ventricle, some in the third ventricle, but it can't drain into the fourth ventricle. It can't communicate. So the lateral and the third ventricle are going to dilate. They're going to blow up. And so that is a non-communicating hydrocephalus. Very important that when someone has a non-communicating hydrocephalus, you do not want to do a lumbar puncture. So here is a patient that has some sort of mass lesion here around the third ventricle, and so the lateral ventricles are dilating. Okay, it's a non-communicating hydrocephalus. The lateral ventricles can't communicate with the third and the fourth ventricle. And so the reason a lumbar puncture is very dangerous in this situation is that when you put your needle into the lumbar cistern, you draw out a bunch of fluid. You know, maybe you think this patient has a meningitis or something, so you just say, well, let's do a lumbar puncture. Patient has a headache or something. Well, when you draw all that fluid out of the lumbar cistern, you are now creating an even more dramatic pressure gradient between the very high pressure here in the lateral ventricles, and now you're creating a lower pressure below that by drawing spinal fluid out. And so this can be life-threatening. This pressure gradient can now cause the brain to herniate. Okay, so in general, and there are some exceptions, but we always want to do a brain scan, almost always, before we do a lumbar puncture to make sure we're not, could not precipitate herniation if the patient has a non-communicating hydrocephalus. Now, a communicating hydrocephalus is most commonly due to scarring out here of the arachnoid granulations. And this can happen, remember this is the subarachnoid space right here. Maybe the patient had a meningitis or a subarachnoid hemorrhage. And what can happen is that can cause some scarring of the arachnoid granulations, and so that in the future then CSF doesn't drain normally. So that can still cause a pressure backup, right, into the lateral ventricle, third ventricle, and fourth ventricle, but they're all communicating. So we call this a communicating hydrocephalus. And you can do a lumbar puncture in this situation because you're not creating the dramatic pressure gradient shift like you do in a non-communicating hydrocephalus. So if you do a brain scan and you just see, wow, look at these big lateral ventricles, you don't know if this is a non-communicating or a communicating hydrocephalus just from this one image. You would need to do other pictures to look at the full extent to see if there could be any mass lesion, for example, that would cause a non-communicating hydrocephalus. All right, so if we just say this is kind of a normal size of the lateral ventricles, here they're large, so this is a hydrocephalus, could be communicating, could be non-communicating. Now here we have big ventricles, but notice what you also see is a lot of shrinkage of the brain here away from the skull. Okay, this is atrophy. This patient has something like Alzheimer's disease, which is causing the whole brain to shrink. And as the brain shrinks, the spaces, including the fluid-filled spaces, are bigger because there just isn't as much brain tissue. Like over here, you've got all this brain tissue around the lateral ventricles. Well, when the brain atrophies, the lateral ventricles look bigger, but also we get a lot of what's called peripheral atrophy as well. Okay, so this would be central atrophy and peripheral atrophy. And when you see that, it's called a hydrocephalus ex vacuo. This is not under pressure. This is not a true hydrocephalus. The ventricles are just big because the brain is shrinking. Okay, so here would be an autopsy of a patient. Yeah, you can see the ventricles are big, lateral ventricle, third ventricle, but just look at all the atrophy here. This is the temporal horn of the lateral ventricle, much larger than normal. Here's the Sylvian fissure, much larger than normal. And so this is just a lot of atrophy. All right, and so if you see this, you don't need to do a big workup, lumbar puncture and all of that. This is due to a neurodegenerative process like Alzheimer's disease. Now a little bit about the blood-brain barrier. There are 3 components. Okay, this is any old capillary, tends to be fairly leaky, but the blood-brain barrier has this inner part which is the most important, and these are called endothelial cells that have tight junctions. So the cartoon is drawn with a lock there to help you remember this is the most important part of the blood-brain barrier. Okay, outside that we have a basement membrane, and then there are these astrocytic foot processes here which contribute, but the endothelial cells with their tight junctions are the most important part of the blood-brain barrier. So why is this important? Well, when we talk about giving medications that we want to treat something that's going on in the brain, you need to come up with something that can cross the blood-brain barrier. So when we talk about all of our medications and pharmacology, this will be important. We'll also discuss systems that destroy the blood-brain barrier, like a brain tumor or multiple sclerosis that kind of distort the blood-brain barrier. And that has some clinical applications. And very important when we start looking at head CTs and MRI scans, we will discuss that you can give contrast agents with CT and MRI scans. And these contrast agents normally do not cross the blood-brain barrier. But if you've got something here like a brain tumor or multiple sclerosis that kind of disrupts the blood-brain barrier, now our contrast agent is able to leak through the blood-brain barrier. And so this will be a very important clue here when we're looking at CT and MRI scans to see, is something disrupting the blood-brain barrier or not. Okay, so what can cross the blood-brain barrier freely? Well, water, oxygen, carbon dioxide, and significant here, especially when we get into pharmacology later, lipid-soluble molecules. Okay, active transport is required to get things across like glucose and amino acids. Now there are areas of the brain that lack a blood-brain barrier, and these are called circumventricular organs. Okay, you can see the pineal gland we talked about lacks a blood-brain barrier. But for now, the one I'd like to just say a little bit about here is the area postrema, which you can see is kind of in the fourth ventricle, lower medulla area. It's midline. Okay, this is sometimes called the vomiting center. So why does it make sense that this lacks a blood-brain barrier? Well, if you've just ingested a toxin or poison or something like that, it's actually a good thing that we don't have a blood-brain barrier because this can activate the area postrema and immediately cause a vomiting reflex to get rid of whatever toxin or poison it was. All right, so infectious disease or microbiology later will give you several lectures on meningitis and encephalitis. So what I'm going to say now is just a very brief overview, but I would like you to know the difference when we use the term meningitis or encephalitis, because there's a lot of overlap. Both meningitis and encephalitis, the patient comes in with a headache and fever. Both really could have neck stiffness. What happens is when you have a lot of infectious inflammatory cells there, it irritates the meninges. And so especially if you were to ask the patient to touch their chin down to their chest, that stretches the meninges. And so that's very uncomfortable. So that's a lot of overlap. But the difference is that a meningitis is just an infection of the meninges and the subarachnoid space. When we use the term encephalitis, we mean not just a meningeal infection, but the brain itself is involved. So the cortex is also involved in the infection. And so clinically, we know that we're not just dealing with a meningitis when the patient has symptoms of cortical involvement, like they have a seizure, or the patient is unresponsive, or if the encephalitis involves the language areas, they have an aphasia, or if it involves the motor cortex and they have focal weakness. So these kinds of symptoms tell us that this is much more serious. I mean, a meningitis is serious, but if the brain itself is involved, that's very serious, and that is called encephalitis. All right, I will not ask you this for this upcoming exam, but it would be a super high yield thing, definitely something you want to commit to memory here when microbiology goes over this with you. High yield for the step 1 exam, to know the different types of bacterial meningitis by age. I would like to say something about just one encephalitis because it's treatable, needs to be recognized. So I'll just say a little bit about herpes simplex encephalitis. So patients present with headache and fever, but remember that doesn't tell you it's encephalitis over meningitis. But then they also have seizures, so it has to be encephalitis. The temporal lobes are affected, and so that often will cause a lot of personality change, maybe even a psychotic presentation. I saw one patient that was admitted to the psych ward because it just looked like a psychosis. And then the patient had a seizure, and it became pretty clear that this was not, a psychiatric condition. This was encephalitis. Again, if language area is involved, and so of course the temporal lobe, Wernicke's area is in the temporal lobe, so that's often involved, and they're usually confused. So that's kind of the presentation. So typically this patient's going to get a brain scan initially, and an MRI would have a much better sensitivity of detecting this swelling, which again is usually involving the temporal lobe, often both temporal lobes. So that's really a key if you see that on a brain scan. Okay, we'll talk about what we find in cerebral spinal fluid in just a minute. And the reason this one is so important to know about is that we have an antibiotic treatment for herpes simplex encephalitis, and you want to give it as soon as possible. And so if we're suspecting herpes simplex encephalitis, we're just going to treat the patient while we wait for the lab tests and things to come back to confirm whether the patient does have it or not. And if they don't, fine, we can stop the antibiotic treatment. There's no harm done by that. All right, so here's an MRI scan. We can see a lot of inflammation here in this right temporal lobe, and there's just a little bit of early inflammation here going on at the uncus of the left temporal lobe as well. So some bilateral involvement. The patient has herpes simplex encephalitis. All right, so here are the things that when we do a lumbar puncture that we routinely look at. We want to know the white blood cells, we want to know the red blood cells, we want to know the glucose, we also measure protein, and we can do other things. So for herpes simplex encephalitis, we do what's called PCR testing, more on that later, and that's how we can just confirm the diagnosis of herpes simplex encephalitis. So we have inflammatory cells, white blood cells, not surprisingly, in herpes simplex encephalitis. It turns out that herpes simplex is rather destructive to blood vessels. And so we get some leakage of red blood cells into the CSF in herpes simplex encephalitis. The glucose in herpes simplex can be normal, or it can go down a little bit. And this occurs because in herpes simplex, you can disrupt the active transport of glucose into the CSF, so you can get a little bit of lowering there. Okay? What are some other things? Well, we talked about subarachnoid hemorrhage. So the main thing in subarachnoid hemorrhage is you get a lot of red blood cells. Okay? Now that also can disrupt a little bit of active transport of glucose, so you can get a little bit of lowering of glucose in a subarachnoid hemorrhage. You'd get some elevated white blood cells, but this is just in parallel with the white blood cells that are in the blood. So essentially you just have blood, which has red blood cells and white blood cells, going into the subarachnoid space, okay, as well as some protein in the blood, so that'll be elevated. Now, a frequent thing that comes up when you do a lumbar puncture is that you can nick some blood vessels with the spinal needle. And so that can cause some red blood cells to go into the lumbar cistern. The patient doesn't have a subarachnoid hemorrhage. This is just what we call a traumatic tap. So how do you distinguish then whether someone has a subarachnoid hemorrhage, whether you just nicked a blood vessel? And so here we need to do what's called xanthochromia. And when you order this, you're asking the lab to take that tube of spinal fluid, spin it down, and if the blood has been there for a while, like the patient has subarachnoid hemorrhage at home, they get transported to the emergency room, it's going to take some time before they get the lumbar puncture. And so that time causes rupture of red blood cells with release of bilirubin into the CSF, and that is called positive xanthochromia. So we see xanthochromia in a subarachnoid hemorrhage. You're not going to see that when you nick a blood vessel and then just send the tube right down to the lab. So this can be helpful to distinguish between those two. The other thing you can do is usually when we send spinal fluid down to the lab, we do at least 3 tubes. And so we can ask the lab to look at the red blood cells in tube 1 and in tube 3. Okay? And if you have a subarachnoid hemorrhage, it's just going to be high in the same in all of the tubes. If you nicked a blood vessel, you're going to have quite a few red blood cells in the first tube, but by the time you get to the 3rd tube, there isn't going to be much left, and so the red blood cells are a lot less in the 3rd tube. Now, what about the 3 types of meningitis? Bacterial, viral, or fungal. So you can see one difference here is that you get a lot of white blood cells in a bacterial meningitis, so really high count is suggestive. But what's really helpful is to look at the glucose. And what you can see here is that glucose is very low in a bacterial meningitis and in a fungal meningitis. So that's very alarming when we do a lumbar puncture and we see that the glucose is very low. Okay, because in contrast, much more commonly, we see a lot of viral meningitis and the glucose is normal there. Okay, so remember you need to do a serum glucose because maybe the patient has diabetes and their sugar is 400. It's really high. So you need to know that the CSF glucose is 2/3 that of blood glucose. So that's what we're looking at. You can see protein is pretty nonspecific. This is not very helpful. It's elevated in just about anything that goes wrong. So what's most helpful here is really frequently the glucose. And then we can do specific testing. I mentioned PCR for herpes simplex. If we have a bacterial or a fungal meningitis, we can have the lab do a culture to identify the organism. Okay, so I already mentioned traumatic tap. Check for xanthochromia. It will be negative in a traumatic tap. Check for red blood cells, which would be high in tube 1 and not so many in tube 3. Okay, so this would be, again, diagnostic of a traumatic tap, not a subarachnoid hemorrhage.